are ready for steps in diagnostic code selection. Again, like I said before in a previous lecture, I want you to fall in love with ICD-10. And the way you're going to do that is by understanding how the process works, how we pick the codes. And now that we've got some of the other steps behind us, let's talk about how we actually pick the codes that we need. So to do a proper job of selecting a code, we have to understand the conventions. We've talked about those. We also need to be able to read the verbiage and understand the terminology that is in the documentation. Our job as coders is to translate what is being written by the provider in the documentation into a code set so that we can collect statistics. And then again, as I always say, it just happens to be a convenient way to get paid. So that's what most people think about, right, is the money, because money talks, right? So if you understand, though, that the reason we code is for statistical purposes, then you understand why the highest specificity makes is why it's so important for us to get to the highest specificity. We need to be able to track the disease process, as well as the treatments that go along with the disease. And all of this information is collected. That's why we know in a specific, well, for the entire United States, for a specific state, all the way down to a specific county, how many cases of a particular type of cancer there is. We know, for example, prostate cancer for men. We know what treatments work for what types of prostate cancer. The same thing for with women and breast cancer. We can identify the type of breast cancer and then what treatments have been effective, and then protocol changes, right? So it's very important that we understand the conventions as well as the diagnostic verbiage and terminology. And that means that not only is terminology and anatomy very important to your knowledge base, but the disease process. Now, this is something that's going to come along as you go. You may have a medical background already, and so you've got kind of a learning curve there that you're ahead of everybody. But if this is completely new to you, don't worry. It comes, and that gives you the opportunity to go out and do more research on your own. If you see a disease or a treatment that you aren't familiar with, I want you to jot it down in the notebook that I told you about, and take some time to go research it and find out more information. That'll help you with those verbiage words that you need to be aware of. Also, we've talked about the index and the tabular. The index is our launching point. That's going to tell us where to go in the tabular. And of course, the tabular is where all the definitions and those guidelines are going to be reiterated. All of those conventions that we talked about in the previous lecture is going to be notated there. Your excludes, your use also, or use an additional code, code first, things like that. So we need to, don't worry, you're going to have those memorized in no time. And again, I'll tell you when there's something that you need to have memorized versus something you just need to be aware of. But those conventions will come. They're also like a legend on a map. Remember, I told you about that? And then it's going to be down at the bottom of your manual so that you can just say, oh yeah, that's modifier, that's a, modifier 50 exempt or something like that. What do we need in the documentation, the necessary documentation? So we look at the encounter notes, whether it's an H&P, a SOAP note, a consultation, whether it's a doctor's visit or it's an inpatient consultation, if it's an op report, all of these types of documentation you're going to become familiar with. And again, if you don't have that medical background, don't worry, because it's going to come with time. By the time you get through the course, you're going to feel a lot more comfortable than you are here at the very beginning. Right? Some of the things that we're going to be able to abstract documentation from is going to be a face sheet. If a patient is inpatient, the face sheet has all of the demographics and information about the patient from their date of birth, the date of service. A lot of times that face sheet will have not only their demographic information, but their principal diagnosis, so on and so forth, things that happen to them. It's kind of like an overview of what happened to them. If we're dealing with outpatient, then they use an encounter form. Uh, Everybody uses electronic medical records now, but we still have handwritten notes, just not as prevalent as we had before everybody switched over to the electronic medical record. But with the electronic medical record, there is all different types of platforms that people use. So that you'll hear terms like Epic, SNOMED, and AllScript, and there's over 50. I was reading an article the other day of the top 50 EMRs. Now, the top 50, so that tells you how many there are. There's hundreds. And uh, it isn't about where the documentation is on the encounter. It's the fact that all of this is standard documentation that's going to be on the encounter, and you will learn where to abstract it, pull that information out to be able to code to the highest specificity. With all encounters, you'll see a problem list. And with problem lists, sometimes you have a little bit of copy and paste. You'll hear us talk about that. But everything that's wrong with that patient. Now, if it's an encounter form and they're being seen for the first time, then that might not be a very long list. But it'll have things like the person has hypertension, hyperlipidemia, diabetes, or maybe they have an amputation, a BKA, below the knee amputation. And again, it could go on forever. It can be chronic or it can be acute things that you're going to see in a problem list, but that's going to be a place for your eyes to focus. Testing results, we don't have to read the results. It's not our job to look at the HbA1c and know what a patient's blood sugar has been for the last 3 months to determine if they're diabetic or not. That's not our job. Our job is just to know that that was done, and that is a test that is done to retrospectively see what a person's blood sugar has been running. So if a person is diabetic or they suspect they're diabetic, this is a test that's commonly going to be provided. We have basic tests that you're probably familiar with from having gone to the doctor's office. And so we're just tracking that these tests were done. That tells us, yeah, that's what they're looking for, to see if the person has a cholesterol issue, if the patient has hypertension, diabetes, chronic conditions and stuff like that. Or maybe it's something acute where the test is a strep test. The person has strep throat. Again, we don't care what the results were per se. We don't have to look at the numbers. That's not our job. We're not clinicians. And if you're a clinician, so you know, but that is not the role of the coder. But just that it was done. So if the strep test was done and then we don't see that the patient had a confirmation of strep throat, but they're put on an antibiotic, then are we missing something? Is there a disconnect there? Was it actually strep throat that you need to code for a diagnosis, or was it something else? Maybe the person had an upper respiratory infection and it's not identified. But if it's strep, then we have a code for strep throat, and we want to code to the highest specificity. So we're drawing those lines and have to look at the tests that were done. Op reports, they can be a lot of fun once you get in there and start reading them. A lot of the information in an op report is what I call fodder. It's not stuff we need to know. However, there can be just 1 or 2 words that changes a procedure. For example, it could be a procedure that starts out as a laparoscopic procedure, and then they have some type of a complication and ends up being an open procedure. So the beginning procedure is laparoscopic, but the ending procedure is open. And at the top it says laparoscopic, but at the end it says that it's open. Well, then we code to it being, open. Now that's a CPT code or a PCS code, but that's an example of how we've got to look at the details. And the details, it's all in the details in the op report when we're abstracting the diagnoses. Just because they start out with an initial diagnosis, they go in and they do a procedure, the diagnosis could change when they get in there and look and see what's going on. Operative reports, again, can be fun. And then we'll have our discharge summary and final notes. With our discharge summary with inpatient, that gives us a running kind of itemized list of everything that happened to the patient while they were in-house, and what the final diagnoses were and what they did to treat those diagnoses um, before they discharged. And the same thing happens with your notes if it's an outpatient. So the person comes in, they have a sore throat, they've been throwing up, and they have a fever. Well, we know, because we've read it repetitiously, that people that have a sore throat and a fever and they throw up, that is a sign of strep throat. Those are signs and symptoms of strep throat. So then we're going to look for that test. Did they do a strep test? Yes, they did a strep test. It was positive, and he wrote that it was strep at the bottom, and it's all in the final notes. And we know what was the treatment, antibiotic, yeah, etc. So these are documentation that we will be looking for that supports our diagnosis codes. Again, if you're not familiar with the different types of reports, like an op report or a discharge summary, we're going to give you plenty of practice in that. Things you need to remember is that kind of like I already mentioned, that tests confirm diagnoses, thus the strep test. Thus, an HbA1c can confirm diabetes with a patient. These type of, there are tests that can confirm whether a person's a type 1 or a type 2 diabetic. Not knowing if you know that much about the difference between type 1 and type 2 diabetes, you will by the end of this course, let me tell you. But type 1 diabetics have to have insulin, and it used to be referred to as juvenile diabetes because they usually found it as a youth. It's congenital, and so you're born with it. Your body cannot handle your pancreas doesn't work, so it can't do the regulate with the sugar and everything. Whereas type 2 is usually a late onset diabetes, and the even though they're both diabetic, the disease process and how it affects the body is completely different. One's insulin dependent and one's insulin resistant. So the tests that are done, even though they're similar tests, the results will be different. Knowing the tests that are done will tell you that they're testing for diabetes, but it may not tell you if they're type 1 or type 2. And just because a person is on insulin doesn't mean they're a type 1 or a type 2, okay? Because a type 2 diabetic could use insulin, but a type 1 diabetic will always be on insulin, no matter what, because their body needs the insulin. There's no choice. But again, a type 2, just because a person's diabetic and on insulin doesn't mean they're type 1. So it's these little things that you learn along the way that you see in the documentation that allows you to confirm diagnoses. The information, if it's conflicting, if you're not sure about anything, there's a process that we have called query. You query the provider, meaning more or less you just ask the provider, can you clarify this for me? But there is protocol in querying because we are not practitioners. Again, we're translators and liaisons. We cannot say, oh, did you mean to say that this patient is a type 1 diabetic? No, you can't do that. You can say, and we're not going to get into the details about query because you'll learn about that later, but we can't lead that provider or tell them, hey, by the way, type 1 diabetes pays out more than type 2. You sure they don't have type 1 diabetes? I mean, again, you can't do that. It's not about money, it's about statistics and being to the high and coding to the highest specificity. There are policies that are in place, and with your organization, whichever organization that you work for, whether it be a facility or a doctor's office, maybe you work for a payer, an insurance company. Again, it's very, very broad, but there's policies that are in place that have to do with compliance. So whenever there's gray areas or situations that are unique to your entity, maybe you work for a podiatrist and they only deal with the feet, or you're working for a therapy that does PT and ST and OT. There's policies and procedures that circle what they do, that make the coding unique. So again, when there's gray areas, then the policy is the compliance officer sets that up. You say, okay, whenever we run into this situation, these are the steps we're going to do, and this is how we're going to code it, so that you can show consistency in the way that you code. And again, we'll talk about that a little bit more. Granularity is something that got talked about a lot when we went from ICD-9 to ICD-10. Now, you guys don't need to really worry about ICD-9 because even though it's still out there, we're far enough along past that that everybody predominantly has switched over to ICD-10. Not everybody is required, though, still to use ICD-10. Some still use 9, and that would be like auto insurance, things like that. But you know, enough time has gone by, enough years have gone by that pretty much everybody's converted. But we didn't have as much granularity in ICD-9 as we have in the ICD-10. And what is granularity? It just means that we're able to get to the higher specificity than we've ever been able to do in the past. And that's one of the things that ICD-10 is known for, is being able to get to a higher specificity. In doing so, the higher specificity even allows us, with that 7th character, to say if this was an initial visit for this diagnosis, a subsequent visit, or a sequela or late effect visit. And then with fractures, we can even say this is a subsequent visit for a malunion of a specific type of fracture, all because of that 7th character. We couldn't do that before. But why is that good? Because we can get to a higher specificity, more details, more granularity when we want to collect statistics. Why do we want to know that this particular type of fracture has a malunion? Is it because that if we do a procedure and put rods in, that we have a better healing process and we don't have to worry about that malunion? Again, it's all about the disease process, quite honestly. Whenever we have diagnoses that are recorded, we want to make sure that we have as much detail to get to the highest specificity. But we also, as our role as liaison, we're working to educate the provider to let them know that we have granularity and this higher detail in ICD-9, ICD-10. So again, the one of the lectures that I heard at HealthCon this year from a provider was brilliant, and I'm going to use these terms that he used. They want to know what the magic word is. They don't want to be led, and you're not practicing medicine by saying this is what you need to code in this situation. No, they just need to know the possibilities, and that what their options are and what the definition of those options are, because our verbiage as a coder is not always the verbiage that they use, and we'll talk about that. Examples of that for heads up for later is things that are termed like history of. What a history of for a coder means something different than maybe it does for a provider. And so we educate them in what that verbiage means to us as in compared to them. And then what's the magic word? They'll say, what, sometimes they throw their hands up and say, what do you want me to say or document, for this? What do you want? Give me the words. Well, it's the magic word. It's like, okay, if it's this situation, the definition is this. So when we see this word in your documentation, then we know it's this code. When we have to choose between the two codes so that we can get to that higher specificity. ICD-10 gives us that specificity and that granularity to be able to get very, very specific, which in turn is better for the patient, right? We get better results when we can get to that higher specificity. We want to look at all of the details. Again, as a liaison for the provider, they didn't get into medicine to code. That's not their job. And they're forced to do that now with the EMRs. They're having to like pre-code things or code things before it gets to us, and we end up auditing it and making sure they picked the right code. However, sometimes they're picking the code, but the documentation is not there. So we want to make it easy for them and give them those key words in the documentation. Says, oh, this word separates this code from this code and then this code. Oh, okay, I understand. Laterality is something that we were given in a higher specificity with ICD-10. That's very, very helpful. And a great example of this is that fifth character. If a person has a femoral fracture, then there's several things that we ask when we have a fracture. And just so you know, fractures, different, not all fractures are the same. So whenever you have a femoral fracture, that there's protocols and stuff in place for that. Now, you don't have to have that memorized, but after a while, you'll realize, hey, there's conditions that are subsequent if a person has a femoral fracture versus just breaking the humerus or the ulna and radius in the arm. It's the largest bone in the body, right? So it's going to make a difference. So look at our definitions here. We have unspecified fracture of unspecified femur. So that's saying I don't know what type of a fracture it was. Was it a compound? Was it oblique? Was it transverse? What type of a fracture it was, and we don't know which femur it was, left or right. Okay. Now, you said, well, how can they even use that code? There's a reason for that code. It's there because this is the beginning of treatment and we really don't have enough information yet, but we need that code, and then we'll get to a higher specificity as the person's inpatient and all the questions are answered. Then we've got next unspecified fracture of right femur. Okay, so we don't know what type of fracture it is. We know the femur's fractured and we know it's the right femur. So notice how the code S72 point 9 is, well, S72 is a fractured femur. Okay, S72.9 is an unspecified fractured femur. Now, remember I told you before that nines tend to be unspecified? Not always, but 99% of the time. Whenever you see a 9 after the decimal, is going to be um, some type of unspecified. So that 9 carries over. We have unspecified fracture of the femur. And that unspecified is not saying which right or left is fractured. No, it's saying we don't know what type of a fracture it is yet because we don't have an x-ray done right. Okay, so this is an ER report. We haven't got the X-ray results back, so we don't know. Is it is it a twisting? Is it a green stick? There's all these different type of fractures you're going to learn about. But we know that it's the right femur, and so that is a 1. Now, predominantly, don't not always, but right tends to be 1 and left tends to be 2 throughout the manual. Not every single time, but 95% of the time. Right will be 1 and left will be, and 3 might be bilateral if you're going to, like if the person broke both femurs, not always. So now we know just by glancing at that an S code is a trauma code, some type of injury. 7-2 is a femur, that we fractured the femur. 9 is unspecified. We don't know what type of fracture it is, and we can tell which, by that next character, we can tell which femur was broke. Is it the right or left or unspecified? We don't know. Okay. Laterality, again, is going to be the 6th character and the 7th character usually, but for initial, subsequent, and sequela. But if we need a placement, okay, where it's not applicable, we'll just use an X. Okay, so don't freak out when you see an X in the code set. That doesn't have a definition other than it's a placement holder. It's not applicable for whatever reason, or we don't have that information. So let's talk about how we're going to start coding. What do we do? The first thing we're going to do is figure out what term we're going to look up in the index. So we're going to open up the index, and our main term is not going to be based on the anatomical site. Usually it's what's wrong with the patient. So what does the patient have? If it's an acute allergic sinusitis, we're not looking up acute. We're not looking up allergic. We're looking up sinusitis. And we know sinusitis is an inflammation of the sinuses, right? So what's wrong with the patient? The patient has sinusitis. What type of a sinusitis do they have? Allergic sinusitis. Oh, is there any more definition to get to a higher specificity? We have acute. So it's sudden onset sinusitis due to an allergy. So what's the main term we're going to look up in the index? We're going to look up sinusitis. And then when we look up sinusitis, we're going to go and we're going to find allergic. and then we indent to allergic. When we find allergic, we're going to see chronic or acute or chronic. And then this is acute. So that's going to give us a code to go look at. So then we're going to take that code and we're going to go to the tabular and we're going to look that up in the tabular and see if there's any other information that we need to know. So we got the main term in the alphabetic index and any notations or anything that you might see. And also it'll give you a list of possibilities to look for in the documentation. So as you're doing a little light reading, just peruse the index when you have time, when you're learning. Just, don't just find the word, but look around there, scan and say, oh, I didn't even know there were those types of sinusitis that and if you see one that is particularly interesting, I'm going to go look that word up because I've never even heard of that type of sinusitis. I want to find out what that is. And then you go Google it and look it up. So then we're going to go and see, is there any instructional notes in the index that says like see also, or, go look at this condition, because the code is someplace else. And they have that where sometimes you're dealing with anatomy. Once you've got that, then you're going to jump to your tabular, right? So the diagnostic phrase is going to be modified by any of the main terms, which that one really doesn't have any main terms. But then we cross-reference if there's anything else, and it tells you to jump anywhere else, right, from the index. We have to trust the index because the index will say things that isn't in the tabular. And the tabular has information that's not in the index. So that's why you never code from the index, but you trust what the index says. So if it says that you are going to code acute allergic sinusitis to acute sinusitis, then that means that it's a parenthetical, that it doesn't matter if it says allergic or not. That word could be in there or it couldn't be in there, but it's the same code. Okay, then when you get to the tabular, you're going to see it says sinusitis acute, and then it's going to say in parentheses allergic. So that means just standard acute sinusitis and allergic sinusitis mean the same thing. Okay, so we knew that because the index told us, and sure enough, when we got to the tabular, it explained it as well. So we don't have to keep looking for something that is a different code. Now, I just made that up in my head, so don't memorize that and say, oh, allergic sinusitis is just sinusitis, because again, I'm just making it up. Always, always, always verify your codes in the tabular. Never code from the index alone, because the verbiage is going to be different, and that's where all of those guidelines, maybe there's a default that's involved there, or tells you to code an additional code, because it's not going to tell you that in the tabular, in the index. You're going to look at any of the instructional notes that are in the tabular. Is it telling you to go and look at something else? Is it telling you there's an additional code? Is there telling you that there's a code that goes before this code that you need to look at? So for sinusitis, not necessarily are you going to have anything, but other things like strep throat, maybe there's 3 types of strep throat, and we have to go put an A code on there to identify what type of strep. Now, of course, that isn't necessarily the case. There is more than one type, but let's look at hepatitis. There's more than one type of hepatitis. And so you're going to code that the patient has hepatitis, but then it's going to say use an additional code to identify what type of hepatitis it is. So then you're going to have to go back and look at the documentation and say, oh, okay, it's this specific type A hepatitis. So then you're going to go find type A hepatitis, which it'll give you a little cheat sheet there in the tabular. So you look at those codes and you say, okay, now I'm going to go in the tabular to that code. It's like, oh, there you go. There's the definition. And that's the second code I'm going to use. I need to get to a higher specificity. The instructional notes in the tabular told me that this code cannot stand alone, that it needs 2 codes to get to the highest specificity. Right? And then you pick the codes and you're done with those. Now, how do we identify the main term? This can be confusing when you first start out, but once you get it, it clicks. So we're not looking at adjectives. I think of it as adjective describing words. So again, when we looked at sinusitis, acute, we're not going to find it under acute. think of that just means sudden onset. It's a describing term. We're not going to look at allergic because it is a describing word. It's not the main term. What does the patient have? They don't have allergic. They don't have acute. They have sinusitis. So that's the word we look up. That's the main term. And you'll get lots of practice with this with your text. So let's look at some of these others. If we have a compound fracture of the left tibia. Now, when we were looking at that fractured femur, remember the specificity? It said it was unspecified, fractured femur, unspecified. And I told you that the first thing that they're saying is what type of fracture it was and which femur it was, left or right. So here we have a higher specificity. We have a compound fracture, that's very specific, of the left tibia. So what does the person have? Do they have a compound? Do they have a tibia? No, they have a fracture. That's what's wrong with the patient. So we're going to go look up fracture. Now, what's the next word we're going to look up? Well, what bone is fractured? It's the tibia. Now, we don't care if it's left or right yet, but so what do we have? The patient has a fracture. Where is it located? At the tibia. So that's one of the bones. That's the larger bone in the lower portion of the leg. The fibia is the smaller bone, and you remember that because a fib is a little eye, so it's the smaller bone, and the tibia is the larger bone in the lower leg. So then it says what, then we get a higher specificity, a describing word. So what is describing? Left. And what is the type of fracture? It's compound. So you're going to be looking fracture, then you're going to end it to tibia, then you're going to look end into compound. And then it's going to tell you, it may even say left or right in the index. So it's going to give you the code to look up. Then we're going to look it up in the index and make sure that there's no other information that we need. How about acute reticulosis of infancy? What does the patient have? They don't have acute and they don't have infancy. They are an infant. So the describing word, or what does the patient have? They have reticulosis. So you're going to look up reticulosis. And this, you may here now find it like under acute and then see infancy, but reticulosis is the word that you're going to be looking up as the main term. Ulcerative esophagitis with bleeding. So what does our person have? They have esophagitis. Well, there is tons of types of esophagitis. What type of esophagitis do they have? They have ulcerative. That's an adjective, a describing word. So we're going to look up esophagitis, and then you're going to look ulcerative. Now, it just so happens that when people have a ulcerative gastritis or any type of, especially internal conditions that have that ulcer, something that is common that happens is they could have it bleeding or not. So it'll say with or without bleeding, or it'll say with bleeding or without bleeding. Okay, so we want to get to a higher specificity. Esophagitis is our first word. What type of esophagitis? Ulcerative. All right, and then is there anything else going on? Yeah, we have bleeding. So that gives a specific code to a higher specificity, and then we'll go look it up. Again, what does the person have wrong with them? They have a fracture, they have reticulosis, they have esophagitis. Everything else is descriptive and allows us to get to a higher specificity. There are times when there is no higher specificity, right? So codes like hypertension. And then you'll see the parentheticals because it doesn't matter. It's I-10, whether they have malignant, benign, essential hypertension, it doesn't matter. They use the same code. Right? So the descriptive words that are in there won't make a difference to the code. But again, if they are there, we want to make sure that we're getting to the root word and then adding the specificity. So again, reiterating what we've already said is that we go to the alphabetic index and then we use the tabular. Don't forget that. Any instructional notes? We want to look above and beyond in the tabular, look up at the top and see, is there anything at the heading of those codes that says, hey, pay attention, you're going to also do this, or there's a default in this situation. All those little guidelines will be reiterated in the tabular. And any instructional notes, like use an additional code also. Those are heads up that you need more than one code. You can't use this code by itself. We have a high specificity of granularity, which just means it's fine details. You know, think of grains of sand, lots of grains of sand. We get to we have high detail. Documentation needs to be detailed. If we don't have the documentation, then we're going to query the provider. It's like, okay, I got 5 codes that meet the description that you gave me in the documentation. I don't know which one it is. So you're going to list those codes to query the provider and let them check off which one it is, and then get back with you, which that's in another lecture. And also, we have to make sure that we're comfortable querying the provider and we know how to do it properly and what are the proper questions to ask. Whenever you're going to code for inpatient, you're getting a lot of information off that fact sheet and the discharge summary that we've talked about. With inpatient, there's coding going on while the patient's in-house. Okay, so your coding signs and symptoms, even with definitive diagnosis, all this stuff's being captured because it's a different world than outpatient. And with outpatient, whenever you have a sign or symptom with a definitive diagnosis, we don't code the signs and symptoms. So the rules are a little different with ICD. So you need to know, are we doing inpatient or outpatient? And then what are the rules or the guidelines that apply for the entity that you're coding for? And where do we abstract the final diagnosis? Well, the discharge summary is going to give that to us. And then what do we do after that? You reference. So another example is cellulitis, and we're going to look up cellulitis in the index, and then we're going to say, oh, well, there's no non-essential modifiers. There's nothing in the parentheticals, or there are things in the parentheticals, and that's all included, and then we jump out into the tabular. So these are the different types of non-essential modifiers that you'll see with cellulitis. That means it'll be in the parentheticals. So it'll say cellulitis, and then in the parenthetical it'll say diffuse. I don't even know if I can say this. Let's see, the hold on, phlegmonas, septic, or suppurative. And each one of those, you really, should go ahead and look and see what those are. If you don't know what the definition to those are, you need to go look it up as it relates to cellulitis. And again, it definitely changes the definition. So one cellulitis code covers all of those. So what are the first 3 subterms that appear for that entry when you look it up? There you go. Then they want to know, oh, the subterms are, is it on the abdominal wall? Is it anaerobic? Or is it on the ankle or lower limb? And when you see ankle, it says C cellulitis lower limb, right? So that means that you're not coding for the ankle, you're coding for the lower limb because the ankle is encompassed into the lower limb when it deals with cellulitis, right? So there's an exception to the rule for coding. So our high specificity isn't ankle, because that's the documentation we have that it's ankle. It's telling you, no, you're going to code it as lower limb, right? So see how the index works with that, right? It's so exciting. We're just breaking into the surface, scratching the surface. We're going to have a lot of fun going forward, and I want you to tell me how you feel like your brain is expanding as you obtain this new knowledge. Again, we're just at the beginning, so you should be a little trepidatious right now and thinking, oh my gosh, how am I going to learn all of this stuff? That's perfectly normal. You should feel a little intimidated. If you don't, that's great. But if you do, don't fret, because going forward, it's going to get easier and easier. Looks like we have a question. Is this just, oh, what I needed? Thank you. Yep, we do CPT too. Don't forget to ask your questions in the club if you have them, if you're joining us outside of the course, and we'll be more than happy to answer those questions for you. All right. Thanks, guys.